Welcome to Dr. Ruscio Radio, discussing the cutting edge in health, nutrition, and functional medicine. To make sure you're up to date on this and other important topics, visit drruscio.com and sign up to receive weekly updates. That's drruscio.com. The following discussion is for educational purposes only and is not intended to diagnose or treat any disease. Please do not apply any of this information without first speaking with your doctor. Now, let's head to the show.
Hey everyone, welcome to Dr. Ruscio Radio. This is Dr. Ruscio. Today I'm here with Dr. Tanya Dempsey, who has been on the podcast before to discuss histamine intolerance and mast cell activation. And today she's back to expand upon that topic and how things like Lyme disease and Lyme co-infections or tick-borne illnesses can tie in and kind of potentiate this whole syndrome of histamine sensitivity and mast cell activation syndrome. So Tanya, welcome back.
Thanks so much for having me, Michael.
It's great to have you here. I want to get into this topic in full, of course, in a moment. Just give people your quick background and bio in case they didn't catch the last time that you were on.
Sure. So, my background actually, is from the more traditional world. And I did my training in internal medicine, did my medical school training at Johns Hopkins School of Medicine, and did my internal medicine residency at NYU. And then quickly or slowly, however you want to look at it, made my way over to the integrative world, as I realized that the traditional model wasn't working for my patients. And proud to say that 7 years ago, I started my practice, Armonk Integrative Medicine, which has grown dramatically. And I'm excited to say that, it's going to be growing even more. And hopefully over the summer, we're going to have our new center built in Purchase, New York. I have Dr. Lawrence Afrin, who has joined me, and he is really one of the world's experts in mast cell activation syndrome. And we're excited for the work we're doing together with research. We're doing, obviously, continuing our clinical work and hoping to teach others and other practitioners the work that we're doing. So it's been really exciting.
Yeah, that is very exciting. Agreed. And it's also one of the things I really appreciate about you and Lawrence Afrin, which is you're both seeing patients, but also participating in clinical research, which really, as I've said many times on the podcast before, gives such a rich breadth of not only knowing the academics and being able to check your bias and make sure that things that you're seeing are significant and meaningful and based in some type of scientific foundation, but also having that clinical instinct, intuition, and experience so that you're not kind of operating with holes in your vision on either side. So yeah, it's such a fantastic perspective to be able to bring here to the podcast.
Yeah. And just to expand on that, the issue is that, when we're dealing with chronic diseases, which is really where my focus has been and where Dr. Afrin's focus has been, and many of our patients have been chronically ill for decades sometimes. And, they've come to us, they're looking for help, we're providing them with answers, we're getting diagnoses for them, and then they have to go to other physicians. And unfortunately, without research, without data, without everything documented in the literature, it's very hard to sometimes convince the, allopathic practitioners that these patients are really sick. And that has really been our goal, is to make people understand that these patients are not making up their illnesses. They are really sick with symptoms that sound bizarre to many out there, but they're not. And we have reasons now to understand why that's happening in these patients. And we need to be able to teach others that, so that other practitioners can treat these patients and also identify other patients in their practice, because we really have an epidemic of chronic disease.
Mm-hmm. And regarding these puzzling symptoms that you alluded to a moment ago, for the audience, just so if someone's listening or reading this, they're trying to say, well, do the symptoms that I'm suffering with, do they connect into this topic? I'm assuming the question would be answered with a definite maybe. But would you say, are there any, just in brief, predominant symptoms that if someone has, they should be extra perked up at this topic?
So, the way I think about this is that there are three main areas that are affected by, and in particular, we're looking at mast cell activation syndrome. There are three areas where people can manifest symptoms. They can have symptoms in all three areas, or they can just have one area. So I would say the more common one that everyone thinks about is the allergic-like phenomena. So it could be hives, it could be, allergic symptoms, respiratory symptoms, asthmatic type symptoms, anaphylactic type symptoms. Some of them are true allergies. Often they're not confirmed allergies. They're actually non-IgE mediated, meaning that it's going through a separate mechanism from the allergic mechanism, but it's still manifesting as an allergic-like symptom. So that is very common, but even if you don't have that, you could still have this condition. And so the other piece of this is really what we call inflammation. So we have the allergic type or allergic-like symptoms. We have the inflammatory symptoms. And then lastly, we have abnormalities in growth and development. So when we talk about inflammation, that inflammation can really affect any organ system, can affect the heart, the lungs, the muscles, the nerves, the genital organs, the GI tract. And so inflammation is very broad. And so it really can encompass a lot of what your listeners could have. The last one, abnormal growth and development, is where we see just that. Sometimes we have people who have these random cysts that develop in their liver, in their thyroid, just random places. They tend to build up these abnormal growths. We know that abnormal growth and development can cause issues with even in childhood with like actual abnormal growth, like maybe growth hormone insufficiency may be linked. There's all these things that, again, they're sort of broad, but they encompass a lot. And so if you think about it, lots of people have some aspect of many of those things. So it suggests that this condition may be more common than we think. According to research coming out of Germany, about 17% of their population, which we're assuming is very similar to our population, has mast cell activation syndrome, whether they're symptomatic at the moment or not. So that's a pretty big number, close to 20%, right? It's 1 in 5 people.
Yeah, that's definitely enough where it's something that clinicians will be seeing at some point, almost certainly at that high of a prevalence. And with the inflammatory connection, certainly that opens the door to almost any symptom, really. The other thing I'm wondering here is how much or little are you looking at gut function as part of this syndrome? Gut function is something I know our audience is curious about. It may be relevant. It may not be very relevant, but what's your perspective there?
Oh, it's extremely relevant on many, many levels. So first, I can just say that we know that mast cells are in abundance in the GI tract. Whether you have this mast cell activation syndrome or not, mast cells tend to be at all those places in the body that are at an interface with the environment. So, you eat food, goes in, those mast cells are there to protect you. And so they're there. So if you imagine that you take somebody whose gut flora may be altered, maybe from their diet, from their lifestyle, maybe they weren't breastfed as a child, maybe they've had lots of antibiotics. There are all these reasons why the gut flora can start to shift. And if you get that shift, those mast cells recognize that there is something wrong. And that often can be a trigger for the mast cells to react. And then that leads down this whole cascade of things that can happen in the GI tract. So you can have things like bloating and constipation or diarrhea or reflux. And you can imagine, right, all those things. We also know that there may be some link between mast cell activation syndrome and autonomic function. So what I'll say is like autonomic function is really the part of your nervous system that controls things that you don't think about. So when you eat food, you don't think about, I have to produce that enzyme and I have to break down that food and I have to move it all the way through the entire GI tract. Your body just does it. And so we think that the mast cells may play a role in the functioning of that part of the nervous system. And so what we see is sometimes people get this condition called gastroparesis, where the gut slows down and food doesn't move through properly. And then that sets up a whole issue with the flora also will be altered. So we see SIBO, for instance, small intestinal bowel overgrowth, quite frequently associated with mast cell activation syndrome.
Oh, quick question there.
Yeah, go ahead.
Do you feel like, is there a chicken or the egg debate there? Or would you say one tends to precede the other more so?
Yeah, I think it's really complex, and I think that it's really intertwined. So I think in some patients who have a genetic predisposition to mast cell activation syndrome, so this is something that they've probably had since childhood that has evolved over time, has gotten worse, that sets them up for this, and then maybe SIBO is what develops after that. But I certainly have a subset of patients who probably the mast cell issues didn't develop really until later. There was really no evidence during childhood. And in those cases, I think it's a secondary problem. And I think it's other things that have set them up for SIBO. And then the SIBO has triggered the mast cell.
And you know what's fascinating there's been a few papers that have posited that either abdominal distension or short chain fatty acids may actually stimulate mast cell degranulation. And so perhaps this is why we see patients with SIBO when they go on a lower FODMAP diet or treat their SIBO, they see such improvements in a broad array of symptoms because they may be greatly reducing their histamine load, which is just one component of mast cell function. And there was one paper that showed an 8-fold reduction in histamine after going on a low FODMAP diet. So you're right. It is kind of this complex knot or web of causality. But certainly, at least in my clinical experience, we see patients who have a diverse array of inflammatory symptoms that can only get better as we improve their gut health. So I'm glad that you're seeing the same gut connection that I am.
Absolutely. And I'm glad you brought the diet piece up and FODMAPs because I've taken it a step further with many of my patients. Now, I always personalize the diet. I don't think there's a one size fits all, but generally speaking, FODMAPs is a good place to start. But it's not uncommon for me to eliminate many of the vegetables from their diet and the fibers and the things that I think are maybe causing more inflammation for them and putting them on a more ketogenic diet where they have more fat, more moderate protein, and almost no carbohydrates. And that really the SIBO really does respond very well to that. And so does the whole gut function. And then their mast cell activation syndrome really does, for many, dampen down. It's not across the board. I don't think if the diet is right for everybody, but when it works, it's really quite remarkable.
Mm-hmm. Yeah, it is remarkable. There's so many patients in my office where we're thinking about MCAS. We've been using the MCAS questionnaire. I know Afrin was part of developing that. Were you involved with that questionnaire development also?
Not the development, but we certainly utilize it in every patient that we see.
Yep. So I've been issuing that to some patients who were suspicious of, and it's definitely something I've had my eye more so on, especially after the interview with Lawrence and with yourself. But it is amazing when I'm saying, okay, this may be an issue we have to come directly to kind of MCAS therapies, but how infrequently we actually have to do that when we optimize someone's gut health. Now, it's also possible I'm fortuitous in the population that I'm seeing, but it does seem that it's only a much smaller percentage of people that we actually go to the over-the-counter H1, H2 antagonist protocol, or then even in considering referring for an MCAS specialist. Because if I've done all the gut work and we've done the over-the-counter antihistamine protocol and we're still not close to where we want to be, that's when I say, okay, I'm getting at the edge of my expertise, and now we'll refer into a specialist. And we have sent a few patients over to your clinic when that has occurred.
Great. Yeah, I think you're right that, there's some groundwork that can be done, and often that can tip the patients over in the right direction. But there are many that we see, by the time they've come to our clinic, they've already sort of exhausted all that. And so, it's our job to figure out why are they not responding the way you think they should respond? based on your experience. And in that case, there's often either residual infection that hasn't been treated, so it's not infection in the gut, but it's a tick-borne disease, or it's a mold exposure, or a systemic fungal infection that may have been precipitated by a mold exposure or precipitated by antibiotics or something like that. Those are the things that I think about. Environmental exposures, what keeps this process going? And sometimes you can get to the root, often you can, and sometimes you really can't find. There are multiple roots, and what you have to do is you just have to really be more aggressive with the mast cells, because no matter what you do, they're just going to continue to be sick. So
Great segue, by the way. And also, do you think it's fair to say, and this is more just a question for the solace of some patients who are kind of hard on themselves, some people's immune systems may have formed to be so exquisitely sensitive to just a somewhat natural environment that, the environment's pretty darn good, even after all the work. And now we just have to go to work on trying to tone down their immune system reactivity.
Yeah, that's correct. I think that, there are some patients who genetically have, I guess I will call it a more autoimmune sort of reactivity, so they're more prone to that sort of reaction. And so they are in hyper alert. Their immune system is in hyper alert, and the mast cell is just one piece of that immune system. So you're absolutely right. You can clean up everything. At the end of the day, the mast cells are going to keep reacting. And, we think that has to do with mutations that happen at the level of the mast cell. This is research that has to be done. Dr. Afrin and I are always talking about, how we would even go about testing this, but that's the key. The key is that there's something about each person's mast cells once they've mutated. Sometimes once they've mutated, that you really can't change them. They're reactive. So you have to use these different modalities to stop them, but you're never going to change their genetic composition. And that's the problem. So if we could figure out how to prevent the mutations from happening in the first place, or we can figure out what those mutations mean for that mast cell so that we can match it with a therapy, that would really change, the quality of life of a lot of people. So that's sort of where we see this, the research going for the future.
Well, hopefully significant strides there will be made. Hey everyone, just wanted to quickly tell you about a CBD that I'm experimenting with currently, and some people on our team have had really good results with, and who have also helped make this podcast possible. NED or NED makes a hemp-derived CBD, and as you've probably heard, CBD can have a wide range of benefits for gut, for anxiety, depression, other neurological conditions, can be anti-inflammatory, and provides antioxidants. I'll include a few links to some of the interviews we've done in the past on cannabis. And we also have to be a little bit cautious because most of the research has been done with full spectrum cannabis, meaning THC also included. But the drawback to THC is it makes you high, and so it's hard to do stuff. So I do think it's worth a trial, and I'm having patients in the clinic start experimenting with CBD only to see if they can reap the same benefits. Many people are anecdotally reporting, like Erin from our team, who saw a massive reduction in her premenstrual cramps, and Josh Trent, who's been on the podcast, who remarked that NED CBD makes his gut feel happy. We checked them out. They are a legit company, no isolates or synthetic ingredients, lab tested for pesticides, molds, and other contaminants, non-GMO, in a base of MCT oil. And they are giving our audience 15% off plus free shipping when you go to helloned.com/Ruscio, RUSCAO, helloned.com/Ruscio. Use the code Ruscio, RUSCIO at checkout. Now, coming back to the topic or the facet of environment, one environmental factor that would be, of course, highly modifiable would be a chronic tick-borne infection. And so we have Lyme and Bartonella. I know you were saying that. And so this is one of the things that really made me curious. And email correspondence between the two of us, you had mentioned that you're finding Bartonella to be fairly common, strikingly common. I think you may have even used the term pandemic in driving the non-responsive symptoms. So tell us about what observations you've made there and lead us into this topic, because I'm sure people are curious to hear more.
Well, first off, I practice in a Lyme endemic region of the country, so it's very hard to avoid. We see so many patients coming in. I mean, it's hard to imagine. I'm trying to think the last time I saw a patient who wasn't exposed to Lyme at some point or infected with Lyme because of where I am. The thing about Bartonella, though, is that while Bartonella can be transmitted by ticks, and that's been proven already, the same ticks that transmit Lyme, and these ticks can transmit many infections, the problem with Bartonella is that it can be transmitted by other insects, and it can be transmitted by spiders and biting flies and lice and fleas. And if you think about the range of insects that can transmit Bartonella, you can imagine that I'm not only going to see it in my neck of the woods because I'm in an endemic region for ticks. We're going to see Bartonella worldwide. And that's in fact what we see. There's a great map that I use in my presentations that shows the different species of Bartonella that are found in like every corner of the world, because there are insects in every corner of the world transmitting these. And in addition, every mammal on this planet can carry Bartonella of different species. So if the animals are carrying it and the insects are biting the animals and the insects are biting humans, or even the animals are biting humans, I'm sure there are listeners who have been bitten by a cat, bitten by a dog, scratched by a cat. And these animals often carry Bartonella quietly. It's sort of, it may not be active in those animals. The animals might not be sick, and it can still transmit it. So when I started understanding that, and I was seeing a lot of Bartonella as I was testing for Lyme, but it became clear to me that I was seeing Bartonella without Lyme. And I was seeing more Bartonella without Lyme than I ever had seen in the last couple of years. So that to me really raised a red flag. And so, the more and more I look for it, the more I see it. And the more I see it, the more I see that there's this link between Bartonella and mast cell activation syndrome. And there's a link between all infections and mast cell activation syndrome. But there are some special things about Bartonella that maybe make it a little bit more likely to happen. So Bartonella is, we call it a stealth infection. And it has a way of hiding from the immune system, and it can camouflage itself, and it can do things that again, like that make the immune system not realize it's there. But at the same time, it's colonizing different parts of the body, including it goes into the red blood cells, it goes into the arteries, into the lining of the arteries and the veins, and so what we call the vasculature. And these are the very areas where mast cells tend to also live. And so if you imagine that the Bartonella invades that area, the mast cells are there ready to fight, you can see how it would get kicked up. And what's really interesting to me is, as I was exploring this link, that if you look at the symptoms that mast cell activation syndrome causes, and you look at the symptoms that Bartonella causes, they overlap completely. Bartonella can affect every single organ system. Mast cell activation syndrome can affect every organ system. So you start to wonder what is the link. And I think that many of the symptoms that people have from Lyme also, and Bartonella and Babesia and all those co-infections, are being driven by the mast cells, so that the symptomatology is coming from that, not necessarily the infection itself. And the treatment also can lead down that same path. So one of the challenges we have with patients who have both a mast cell issue and an infection is that you try to treat the infection and their mast cells go nuts, and they get sicker and they can't tolerate treatment. So this is where this is really important, where I'm looking at ways to deal with the mast cells, calm them down, get the patients in a better state, so that if there is still active infection, we can go after it and they won't be as reactive. So I just want to mention one thing. There's this term that we use in the Lyme world called Herxing, the Herxheimer reaction. And really, I believe that that's a mast cell reaction.
Very interesting. But it makes sense. It makes sense if someone has an infection, but they're just hypersensitive to treatment. It might not be a quote unquote die off. It might more so be an issue of immune system reactivity. And I've levied that same criticism on the podcast in a slightly different but similar analogy, which is some people who feel that they have to spend 5 months working up to a full dose of a certain antimicrobial. And actually, Allison Seebecker and I were having a conversation about this yesterday. That, to me, when someone has to start off with taking let's use a probiotic as an example, with an eighth of a capsule of a probiotic, and they can only get up to 1 full capsule by month 5 or 6. That sounds an awfully lot like allergy desensitization therapy, where they might be allergic to the compound. And so it might be an allergic reaction, not a die-off or a detox reaction. So, what you're saying is brilliant. And I think, yes, sometimes it's not that you're having this, Herxing die-off crisis. It's that the immune system is overreactive, and we've got to find a different approach to be able to get to the therapeutic endpoint we're trying to arrive at. Correct.
You're absolutely right. Yeah, and that's a great example.
Now, the challenge here is the testing piece, right? Testing, it's not perfect in many different realms, and this shouldn't be a surprise to anyone on the podcast because it's been a reoccurring theme. But especially with Lyme, at least in my observation, it seems very hard to get a straight diagnosis. And I know one of the things that we had discussed also via email was some of the larger labs, like LabCorp and Quest, you found very difficult to see a positive profile, wherein you may have seen, I'm assuming, a positive via another test, maybe IGeneX, or just the patient responded to treatment. So this, in my mind, is the biggest hurdle. How do clinicians grapple with the diagnostic part being so challenging to know, well, this person's already reactive. So we already have to be so careful with the therapies that we employ because we run the risk of flaring them. So we really want to try to be as precise and as guided as we can. And then if the testing we're using to be precise and guided is ambiguous, it poses such a conundrum. So how do you navigate that?
Yeah, that's for sure the challenge I face every single day, every single patient. I want to be clear that not everybody with Bartonella or Lyme or co-infections have mast cell activation syndrome, and vice versa. Not everybody with mast cell activation syndrome will have had an infection or these Lyme co-infection type things. You can have one or the other, and they can be unrelated. I tend to see a population that is overlapping, and they are related. So, what I need to do is I do need to piece it apart.
Really quick, is one of the reasons that is, or one of the presentation pieces, that these patients are just highly reactive? Is that kind of the unifying theme, sensitive patients?
It's a good question. Yeah, I think that's probably a good way of putting it. I guess your question is, how do I identify the patients that have both? Is that the question?
Or either. Some patients may just have Lyme. Some patients may just have mast cell activation syndrome. Some may have both. But I'm assuming a non-MCAS Lyme patient may just go right through therapy, not have many bad reactions, and be fine. But then people that have both, or people who just have MCAS are reactive to many types of therapy. So is it the highly reactive nature that is the commonality of MCAS plus or minus other conditions?
Yeah, I think you're right. That probably is that unifying character. Having said that, I have had patients who have been treated for Lyme and co-infections and have had aggressive antibiotic, herbal, homeopathic regimens, thrown at them, and have tolerated it quite fine. Although they do have this history of being maybe a more allergic type of person and more inflammation and things like that, but they tend to sail through it. And then they go off everything, they do well for a while, and then they quote unquote relapse, and they feel like their Lyme symptoms are back. And then you say, oh, okay, well, now we just got to go back in and do the work again. And now they react to everything you give them. And so I see a lot of that. And I think that is that they probably had mast cell activation syndrome, but maybe it just wasn't primed, or it was quote unquote quiet, And we don't know why. Maybe it has to do with these mutations or lack of them. But then at some point, it's either that the infection really did come back, or the body thought the infection came back, and the immune system just got revved up, and boom, and they look like they have a recurrence of infection, and in fact they may not. And that's the challenge. We got to try to figure out if there's still active infection, or are we just dealing with a progression of this immune dysregulation? Mm. And the testing we have is really not enough in that world, right? So we have pretty good testing for mast cell activation syndrome. It's not perfect, but we can usually make a diagnosis. But on the flip side, we can do IGeneX. We can look for markers that suggest persistent infection. We can do PCR testing to look for whether we can detect the DNA of the bugs, and we can still not know for sure if it's all there or not. Bartonella in particular is really difficult because it's hiding everywhere. And if you do blood work and you're looking for an immune response, or you're looking for antibodies, but the body is not producing antibodies because the Bartonella is hiding in these other places, right? You may not see it. It might look like you don't have it. And you could try to get PCR, but again, if the bug is hiding and you're drawing blood, the DNA may not be in the blood from the bug. It's hiding in whatever organ. So it is challenging. So the key is, how do we really confirm or rule out that the patient has an infection or not,
And one of the things I'm wondering, the viability in the approach you would see here would be using treatment as a test, because that was one of the things that, as we were having our conversation, I was saying, gosh, it'd be great if we could develop a questionnaire that tried to partition, let's say just arbitrarily, the top 3 to 5 tick-borne infections, what their most commonly presenting symptoms are, and we had a corresponding therapeutic protocol that you could use. So if someone subjectively flagged, you could then use a trial of, let's say, 4 weeks or whatever the trial period should be. And then if you're seeing movement of their symptoms, that tells you you're on the right track diagnostically. That might be easier in theory than in application. But how do you feel about that as an idea? And if you like it, can I commit you to working on that project?
Let's do it. I think it sounds interesting. I think it'd be hard to know if it would really work, right? And so we could come up with this questionnaire, we can develop it, and then we can study it. We can publish our data on it to see whether it really is predicting what we want it to predict.
Well, I mean, I would love to have something like that, because one of the things I grapple with as a clinician who's not a specialist in this, and that's maybe one of the things that I'm trying to achieve with this conversation and with this whole proposal, is how do we help non-specialists, be able to grapple with this somewhat successfully? Right? Because I think you'd like to see more doctors being able to offer this to patients. I'd love to be able to offer this, but I don't feel like I'm qualified. And some sort of checklist like that maybe could knock off 40% of cases. 40% of cases, just as an arbitrary example, may respond to that simple protocol. And the other 60% still need that specialty referral. But that would be, in my mind, a huge step forward.
Yeah. And that brings up a really good point. I think that there are plenty of patients out there who have been exposed to these tick-borne infections, and they get sick, or they don't feel well. They have symptoms, but they are not to the degree of really chronically ill yet, right? And those are the patients that this sort of questionnaire would really target, because these are patients that you're either catching early enough, or their immune system is still intact. And then you can do the work that you need, and you can move them to the other side. I use this example sometimes with patients. If I pull 50 patients off the street in front of my office, because I work in an endemic region of the world for Lyme, and I pull 50 people off the street and I test them, 90% of them probably will test positive for Lyme disease in some form or co-infection. But not all of them are sick. And some of them might have subtle symptoms. Some of them may be really sick, and some of them will have nothing, right? And so if you target with this sort of questionnaire those patients in that middle ground. They have some symptoms, no one can figure it out, and then you can target therapy, right? I agree with you. A lot of them would get better because their immune system, for some reason, is handling it differently. And the question I always raise is, why do some people get to that severe chronic stage where, all these therapies have been tried and nothing is working, right? Those are the patients that need, those specialists. But those middle ground patients, right? I think there's a lot of work that other practitioners can help them with.
Awesome. Well, I will follow up with you via email. For the audience, we're not promising anything. We're going to give it a shot, but
Yeah.
I have a feeling this is much easier said than done, but hopefully we can get it done.
Yeah, I think we should explore it for sure.
Great. So coming back to the testing, is there something that you want to kind of leave practitioners with there before we move on to treatment in terms of tests you like, or how you are getting through that quagmire?
Yeah. Well, so as far as testing, you want to talk about the tick-borne testing specifically?
Yeah, I'm sorry. Yeah, if someone's thinking, okay, there's all these symptoms here, maybe these chronic symptoms are due to a tick-borne, but it's kind of complicated. What might I do?
So I think that you could really start with, what I call the regular lab testing. There are markers that suggest that there is some chronic infection going on. So it may not point the finger to the exact infection, but for instance, if I do blood work and I see a VEGF level, vascular endothelial growth factor level, which is it's really a marker for inflammation. I call it a chemical hormone that's produced by a number of different cells in the body. It's meant to help your vasculature, your arteries, your veins, all those to be healthy and allow oxygen to flow through them. So it's an important hormone, but you want the right amount of it. You don't want zero and you don't want off the charts. And so I sometimes use that as a marker for inflammation. And specifically, there is some correlation between Bartonella and elevated VEGF levels. So I might say if somebody has an elevated level, it might suggest that I have to do a little more digging for the Bartonella. So I like to use markers and combine that with the specific testing. Really, the best test I think right now for Bartonella is Galaxy Labs. They do both antibody testing for Bartonella hensleyi and Bartonella quintana, which are the two more common species that affect humans. But they do PCR testing for all strains of Bartonella. And so far, that's been the test that has been the most helpful in identifying, at the very least, exposure to Bartonella. And then, hopefully can help confirm a true infection. IGeneX can be very helpful too in a variety of different ways for other things. So those are the two tests that I'll do. But the problem is that they are very costly and not every patient can afford that. And that's where we have to rely on some of these markers. We have to rely on clinical symptoms. And that's sometimes the best we can do.
Gotcha. So just trying to connect back to that project we discussed a second ago, would you say the questionnaire, and potentially if the questionnaire flags, if you want to be ultra conservative, you could pair that with a positive VEGF. And if that was positive, that gives you a fairly high clinical suspicion that you should move forward into whatever the connected treatment protocol would be?
Yeah. And if I don't have real confirmation of Bartonella, I'm going to be reluctant to put them on antibiotics, but I certainly have herbs. I sometimes use homeopathy, and then you can sort of get a sense from how they respond whether you're, on the right track or not. If they start to say, it's doing something, I maybe feel a little better, you think, okay, this might be. If they start having negative reactions to the herbs or whatever you're using, I have to determine if it's a mast cell reaction or really a die-off reaction. And that becomes a little more complicated. But if they respond positively, then I have some proof that we're on the right track.
Now, do you find time helps you to parse that? Meaning if it's a mast cell reaction, their negative symptoms are going to persist almost indefinitely. But if it's a die-off reaction, they'll kind of come, appear and then fade away over the course of a week or so.
Absolutely.
Okay.
Absolutely.
Good. So we're in agreement there, because that's the same thing that I've seen.
Yep.
Okay. Now, another area that we seem to be in agreement is regarding treatment, where my parallel of GI to your parallel of Bartonella and other like infections here, I'm noticing that for sensitive patients, I have to use more of a single ingredient formula rather than a combination of multiple herbs. And it seems, at least when we were emailing, you agree with that same general type of approach. With that as a springboard, how are you treating, we can't get into all the details, obviously, but what are some of the salient points regarding how you're treating these things?
So, again, I do want to, in these patients that I think are very reactive and have histamine issues, have mast cell activation syndrome, I'm going to really want to stabilize them from that perspective first, right? So we are looking at the gut, and we're looking at the diet, and we're looking at, their exposures. If they're living in a moldy house, and they also have Bartonella, and they also have mast cell activation syndrome, it's like, no matter what I do, if I don't get them out of the moldy house, nothing's going to work, right? So you really have to eliminate the triggers that you can control. Now, sometimes they can't control that they're in this house. They have nowhere to go. And I wish I could find a way to build some housing where I can put patients who have mold toxicity and just get them out so that they could, recover. That's my dream, to establish something like that. But in the meantime, we do what we can to help stabilize them. And then if we still feel that there's infection there, well, I should say that if we still feel that the mast cells need work, I've got to deal with that. And so whether it's, the natural antihistamines like quercetin or vitamin C, or whether I'm going to the H1, H2 blockers over the counter, or then, obviously there are lots of other steps. I really want that in place before I start trying to treat the infection. I do want to say on the flip side, I have patients who, when I start treating their infection, their mast cell symptoms come down dramatically. So I also know that I can't waste so much time doing that if I really think that infection is the driving force. So I'm always balancing in each patient. And then I'm doing, it's always one intervention at a time, one ingredient at a time. We're always looking for filler issues. A lot of these patients react to things like cellulose in the capsule, in the powder. So it's challenging that way. Sometimes we use tinctures. Sometimes they're better tolerated. Sometimes they're not. Again, very individualized. So we're sort of overlapping the treatment, trying to see how much is infection driven. And then, if I need to, then I'll pull out the big guns, the antibiotics. Sometimes you can't do everything herbally sometimes. And then I pull out the big guns if I need for the mast cells too.
Gotcha. Yeah, it makes a lot of sense that you're trying to find the right balance between kind of quelling an overzealous immune system and when to go right after the infection. And I think that makes a lot of sense. So that's a good kind of theoretical premise for providers to be cognizant of. And then if they're familiar with the treatments in those different areas, they can select therapies that would, hit each endpoint: mast cell stabilization, immune system stabilization, or direct therapeutics against Bartonella. And regarding the Bartonella, are there a few companies there that you think stand out if providers are looking to dig a little deeper, where you would where would you point them
for treatment?
Yes, for treatments for Bartonella.
Yeah, so I would say that my top choices for herbs would be things like Sitta acuta. Mm-hmm. I like woodland essence for that. Petunia is another one that seems to be Bartonella specific. Those are probably my top two. Kumanda, which is made by the, I think it's Nutrimetics line, is another one that seems to cover Bartonella. And then there's these other kind of immune supporting herbs that, sometimes you need, like resveratrol and green tea extract and things like that. But again, everything has to be very individualized. I mean, I think that's, the main take home point to those who are watching, who are practitioners, I would say that number one, you have to individualize. Every single patient is different. And I see sometimes when I get referrals that, there are some patients that I'm seeing from specific practitioners that are all sort of on the same protocols or doing the same thing. And sometimes that works, for a subset of patients, but these patients who are really, really sick, who have mast cell activation syndrome, who have been sick for a long time, a one size fits all is not going to work. So, I could love Sitacuta in the last 3 patients I saw, but I have patients who cannot even take a drop of that. Right. So I need to always go back and look at the patient and look at what they're dealing with and what else they have that I'm not thinking about. So again, if I'm going after Bartonella, but they have mold issues or other environmental triggers, or they're still eating gluten or, whatever, nothing I do is going to work. But those are my top herbal treatments for Bartonella. I do tend to stay away from Byron White formulas for these patients. I don't know what your experience with Byron White is. They're fabulous drugs, but fabulous herbs, but there's so many herbs in each formula.
Right. Yep. That's I had Byron White in mind when I was referring to kind of the multi-ingredient lime formulas, and I do think the Byron White formulas are fantastic and can be terrific. But if someone's highly sensitive, the multiple ingredient nature of them makes them a little bit more dicey.
Exactly.
Hey everyone, this is Dr. Ruscio. I quickly wanted to fill you in on the 3 main resources that are available to you in case you need help or would like to learn more. Of course, I see patients both via telemedicine, via Skype, and also at my physical practice in Walnut Creek, California. There is, of course, my book, Healthy Gut, Healthy You, which gives you what I think is one of the best self-help protocols for optimizing your gut health and, of course, understanding why your gut is so important and so massively impactful on your overall health. And then finally, if you're a clinician trying to learn more about my functional medicine approach, there is the Future of Functional Medicine Review, which is a monthly newsletter, which is a training tool to help sharpen clinical skills. All of the information for all 3 of these is available at the URL drruscio.com/resources. And in case you're on the go, that link is available in the description on all of your podcast players. Okay, back to the show.
And I'm glad you said that piece about gluten because, and I just to share my personal experience with all of this with the audience, because I think it is a good reminder of kind of the simple clinical order of operations. Mm-hmm. I was convinced I had a Bartonella infection due to this kind of migratory joint pain and fatigue that I was experiencing. Okay. And I ran some testing, a LabCorp profile, multiple antibody assays for whatever the different Henselay, and they have 2 or 3 different antibody profiles they offer, and PCR, and everything came back negative. However, I went on a herbal treatment protocol for Bartonella, and I felt so much better. So convinced still that I had Bartonella. But this is why I think it's so important for clinicians to be objective and to isolate variables, because you can easily see a false association, which I did. Later, the symptoms returned, and I went back on the protocol, and the symptoms didn't get any better. And I finally figured out through observation and trial and error that I was eating more gluten than my body could tolerate. And I had been ardently avoidant of gluten for many years. And then as I learned more about the issue, I discovered that not everyone has a problem with gluten. So I kind of opened that part of my diet up. But what ended up happening was I was consuming gluten habitually. I'd have maybe 1 or 2 beers, regular beers in the weekend. And, if there was whatever type of gluten, I'd have some. And I was having gluten probably 3 to 5 days per week. And I think that was more than my system could handle. And it was when I throttled that back to only the occasional splurge that I saw all of those symptoms go away and never come back. So, we don't want to make everything caused by gluten on the one hand, yes, but we also want to make sure that we revisit some of these basics, because if a patient comes in and tells you that they're eating a really healthy diet, that healthy diet may have a different definition for a different patient. So albeit this is rudimentary, it's just something to double check to make sure that you're not going after phase 4 or 5 therapies when you've missed phase 1, which would be just getting the diet tucked away.
Yeah, thank you for sharing your experience. Actually, that's it does make a good point, and I'm sorry that you had to go through it, but I think you learned a lot, obviously, about yourself and your patients. But that's the truth, right? And that's where I think where you say, you're not a specialist, you're not a Lyme specialist, right? You may not feel comfortable treating those really complex patients, but the work that you do is tremendous, right? You do help a lot of people, and that's because you get to the root. You're dealing with things that sort of the base, right? You've got to establish that base, so that the foundation, I should say, so that the other work that has to be done, if they're not getting better with that foundation, then we can institute these other treatment protocols, and they'll be better at accepting those treatment protocols because you've done that work. So, when I see a patient who comes to me and says, they're not getting better on this protocol, and I have them on antibiotics and herbs, and then I go, every visit, I always ask them about their diet, and I'm good. Oh, but that's okay. You know what? Why don't you just run through a typical day for me? I always have to run through a typical day. And they run through the day, and it sounds pretty good, right? But I'm still suspicious. And I say, okay, so that is how many days a week do you do that? Right. And then it comes out that they're grabbing the bread at the dinner table, in a restaurant, and they're having a sip of beer, like you said, or they're having things are entering the equation. And then, I think, well, maybe they're not getting better, not because what I'm giving them is not working, is because they're introducing more inflammation, and their immune system can't deal with it. So I think you make a great point that we have to set that foundation. Patients need to understand that they have to do the work, which is hard work, in getting some of that stuff eliminated.
Yeah, it is. But I also tell my patients that it's not forever, right? Let's get you to a point where you have no symptoms, and then we can start opening up the boundaries and figuring out what you can and can't do. But if you're trying to get to the point of no symptoms, you can't be missing these foundational pieces. It just doesn't make any sense.
That's right.
Awesome.
And the gluten piece, I think, is really, it is more critical than we think. And the question is, and you bring it up, what happens in the future for these patients, and I do the same thing. I say, we don't know what the future holds. Let's do this now. Let's get you better. And then we'll re-examine. But I do wonder whether gluten really isn't good for most people.
Well, certainly I would think in a somewhat chronically plagued by symptoms population, you're going to have a much higher distribution of people who don't do well with gluten at all. Well, great. This has been a fantastic conversation, Tanya. I always enjoy connecting and talking through some of these points. Do you want to refer people to a website or a paper or anything?
Yeah, absolutely. So, my website is Dr. Tanya Dempsey, no periods there.com. So drtanyadempsey.com. I post blog posts on there. And my Facebook is Dr. Tanya Dempsey. I have a Facebook Live event that's going to be coming up in May, which I think that maybe your listeners will be interested in. We did a Facebook Live event last month, which was really great. It was very successful. We answered all kinds of questions about mast cell activation syndrome, and I'm sure there'll be questions about Lyme and other things too this time. So if anybody wants to check out the Facebook page and the announcements for that coming up, and stay tuned to information about the new center that will be opening hopefully by the end of the summer. We'll have exciting opportunities for practitioners. I'm hoping to bring some more people on board. So those listening, if you might be interested in joining us, definitely reach out to me via these different places. And I'm excited to see what comes next.
Awesome. Well, thank you again, Tanya, for being here. It was a pleasure chatting.
Thank you so much for having me. It was really great. Thank you.
Awesome. You're welcome.
Thank you for listening to Dr. Ruscio Radio today. Check us out on iTunes and leave a review. Visit drruscio.com to ask a question for an upcoming podcast, post comments for today's show, and sign up to receive weekly updates. That's drruscio.com.